Hi, this is Cindy Zolnierek. I am Chief Executive Officer for the Texas Nurses Association, and I welcome you to this special webinar, Crisis Standards of Care, Ethical Challenges of COVID-19. Right now, you're in listen-only mode, but you can submit questions at any time using the chat box. Questions and comments will be answered at the end of the presentation. Now I'd like to introduce our speakers. This evening, we will hear from Dr. Catherine Robichaux, who is currently an adjunct professor at the University of Texas Health Science Center, San Antonio, as well as the University of Mary Bismarck. She currently teaches in the Nurse Educator Program in North Dakota. Her clinical background is in adult critical care, where she has taught at graduate and undergraduate levels. For the past 12 years, she's taught, published, and her research focus has been in ethics. She served on the revision of the Code of Ethics for Nursing in 2015, and on the ANA Ethics Advisory Board from 2014 to 2018. She's currently on the Ethics Education Subcommittee and the Ethics Board liaison to the work group revising the ANA Scope and Standards of Practice for 2020. Welcome, Dr. Robichaux.
Thank you.
And Jeanie Sutherland is our other presenter. She graduated from Texas A&M University with a BS in Community Health and did an internship in Health Systems Planning. She received her BSN from the University of Texas Health Science Center in San Antonio. She spent most of her direct patient care career in ICU, PACU, and home health. The ICU experiences in particular raised her interest in ethical concerns. That interest was further cemented by her experiences as a parent of 2 children with autism spectrum disorders. Jeanie completed a certificate program in clinical ethics through the University of Texas MD Anderson and completed her master's in bioethics and health policy from Loyola University, Chicago. She is currently on the TNA Policy Council and Education Workplace and Advocacy Committee. So welcome, Jeanie.
Thank you.
As an introduction and to provide some background for tonight's webinar, I want to let you know of kind of where this came from. I am invited to attend a weekly, every Saturday morning meeting of the Texas healthcare industry strike force on COVID-19. We've had 2 meetings and will continue to meet during this crisis. This group is made up of 14 organizations that have been invited to participate and really try to strategize a coordinated response to the crisis we're in. One of the actions that we took following our last meeting was sending a letter to Governor Abbott requesting that he adopt critical care guidelines to guide care during this crisis, when we may indeed face what perhaps most of us have never encountered before, and that is where our resources, both personnel and supplies, do not meet the demand, and we may need to be making very critical decisions about the care that's provided. Because I think this is a new topic for most of us, unless perhaps you've been in the military that have to triage on the battlefield, this is something that I think nurses will struggle with, will experience moral distress about. It will raise ethical concerns for us. So it's important that as much as possible, we are thinking about this and considering it beforehand and feel somewhat equipped with our understanding of our own ethics as we encounter these situations. So I'd like now to hand off to the 2 co-presenters, Catherine and Jeanie.
Thank you. Go to the next slide. Okay, we talk about ethical principles in the face of a pandemic. Again, as Cindy mentioned earlier, we're switching normal paradigms. What we typically do, we are the patient advocate. We are there every day, generally looking at the one. In Western societies, we tend to focus on autonomy as the primary principle. But in a public health crisis, there's a lot of other considerations. One, what is fair? If you're on any kind of message boards right now, those are just on fire debating that very topic. Something that can be applied to one and all, that doesn't discriminate on any arbitrary criteria, whether it has to do with your race, your disability, your economic status. There's just so many factors. So we want to make sure that it's fair, that we honor our primary commitment to care for people, that we don't abdicate that in this, and that we're wise stewards of resources. That is something that we talk about in normal situations, but when you're in a public health crisis, it becomes very important, very front and center, because we do have limited resources. We also have to be transparent. We can't have closed door discussions where there's not input from primary stakeholders, the public, the hospitals, the healthcare providers. What are we doing here? And we need to be consistent. So the care that we give, the decisions that we make, again, don't vary depending on who the person is or what the other factors might be that are not just. And it has to be proportional. Again, they're commensurate, so the degree of harm or gain or whatever is significant to the emergency. For example, today somebody was said, you know, we're not in crisis mode yet. We are preparing, so let's not, quote, pull the trigger and start denying people admission just arbitrarily, that we need to be proportional to what's going on, and that we are accountable for the choices and the decisions that we make. So as a healthcare provider, our primary duty is to care. That's what is expected of us. That's, if you look at the code of ethics, not just for nurses, but for physicians, social workers across the spectrum, that primacy of looking out for others, to care for others, is there. That's what the public expects. That is our commitment to them. We are licensed. We are licensed by the state, or we're given special authority to either practice medicine, to dispense medicine, to make assessment decisions because of that trust. And most people don't have that kind of training or expertise. So we're called upon to a high standard, and we're expected to have a high standard. Nurses being the most trusted profession, it's something we have to live up to. And these aren't transferable. I can't decide, wow, we've got a nursing shortage, we're in the middle of a pandemic, so I'm just going to knock on my next neighbor's door and say, hey, I need some help here, can you do it? Because there's so much education, learning, and skill building for a period of years. So it's something that you just can't replace.
And I know we're hearing about certain places or some schools, and actually Governor Abbott has done that also, to sort of grant early licensing to relatively new graduates, and the debate about, you know, what to do with those individuals if they do come into the workforce. Certainly don't want to throw them in the ICU, and also retired nurses coming back in. So it's increasing the workforce, and might make it a little bit easier for those who are really, you know, encountering these issues every day, to have some help. But then again, you also have to think about the risk to those individuals as well.
Exactly. And if you were the nurse manager, to be able to triage them to the proper duties that they can do, that they do have the training. For example, if they haven't run a vent or, you know, titrated drips in a long time, that's the absolute last place you would want to put them, even if they have done it before, but maybe they're still really good at basic assessment skills of comforting patients, all those things that are going to be very important. And we are taking these duties on, knowing that there is some risk involved, particularly in a pandemic, and that's part of the ethical issue that's facing nurses right now. So, healthcare organizations have a duty to protect those that are working for them. That means giving them enough time off so they can rest and they're able to come to work, having the protective equipment that they need, the supplies that they need. Again, I like the idea, this came from the Hastings Center, that there are 3 primary duties they look at: the duty to plan and to manage uncertainty. Ideally, these plans would have been put in place years ago, but we're learning as this has come up. I've never seen anything like this in my lifetime, I know. So there's all kinds of uncertainty because it's unprecedented. But as much as you can, you want to manage that uncertainty and say, this is what we're going to do if we encounter this, and so forth. Again, you want to safeguard, support your workers, providing whatever equipment, supplies, whatever they need to the best of your ability to protect them and to protect those vulnerable populations, because I think about the people that are homeless, I think about people with disabilities, I think about incarcerated patients or incarcerated populations. They're I don't know if you've seen the memes where there's like 5 matches and they move match 3 down. It says, it just takes 1 to stop or to start the flames. So we have to be particularly vulnerable, and to have not just the crisis, but what are we going to do, the contingency plans to help us towards this.
Yeah, and I think in Texas, we actually have an opportunity because we are a little bit ahead of the curve or the surge or whatever you want to call it. And this duty to prepare should be really what we're focused on right now, to the healthcare organizations as well, to find what is needed for the anticipated however many numbers they're expecting to come in. And also for the vulnerable populations, as Jeannie said, I think I heard in the news the other day that there was some prison somewhere where some of the inmates were testing positive. So, maybe that's not our practice area, but what happens there? So it's really, I think we have an opportunity in terms of thinking ahead. I think Cindy was very prescient in putting this together now, just to forewarned is forearmed, to get things in place. And Jeannie's sort of in the thick of it right now where she is. So, they're preparing obviously, but I think everyone else should as well.
Agreed. So there's different ways to describe triage models and whatnot, but I like this because it's very straightforward. You have conventional capacity, business as usual, right? Ordinary thing. I would say right now most of us are in the contingency. Life is not as usual. We are being very cautious about using supplies to make sure that we have what we need available, and not overusing, not wasting, and generally, but the patient care itself is adhering to usual standards. We don't deny people because of what might be. We try to do the best thing to adhere to standards of care. When we get to the crisis capacity, that's where everything becomes completely disrupted. We're doing the best we can. There's all the things that we've conserved we're now using. We may have to reuse. We may have to adjust the normal standards because we don't have any other choice. Again, that's we're overwhelmed by the demand compared to the.
Yeah, we're seeing that in Elmhurst, Queens. I mean, the hospital in Queens, it's been on the news every day with just being overrun.
And the hot spots, I think, Detroit, New Orleans, of course, all these things. And that's in the United States. I mean, Italy and Spain and other countries have already gone through that. I'm not sure they're out of the woods yet, but it's very real. So, again, we can go to the next slide. You could see the nice thing, and it's interesting that as you conserve and whatnot, as you come to your care, the quality of care is going to go down. And that's not, it's just the reality of the situation. You're doing the best you can in the given situation with the resources you have. You're adopting, you're using, you're reallocating, but that may be a source of moral distress because you know what you should be or you would like to do in a given situation, but the circumstances are such that you just can't. So the primary goal in any kind of medical surge is to prevent or limit the amount of time in crisis and to save as many people as you can, and to avoid harm where is possible. The old Hippocratic oath, first do no harm. We're trying to minimize that. So you will see, you know, these sterilization techniques for the N95s that are coming out. People are talking about when and where you can use homemade masks, and if there's different things that can be used to substitute for that have the same effect of protecting staff. Telehealth appointments. I know that I had a procedure that was scheduled that's already been canceled because it was considered elective, and my routine PCP visit, they called me and said, hey, we're going to do it by televisiting, which is fine, you know. I'm thankful we have the technology to do that now, but you're seeing that so we can conserve the equipment for when it's needed.
So you might think about, if your institution or wherever it is you're working have implemented some of these contingency plans in terms of the things that Jeanie just mentioned about conserving and substituting and adapting.
Exactly. And I think we also have to be careful that some of our patients don't have access to the technology, and we need to look after. I listened to last night, the ANA president was on NPR, and he talked about let's not use social distancing, let's call it physical distancing, and referred to a heat wave they had in Chicago where people just weren't checking on the elderly who didn't recognize they were going into heat stroke exhaustion. So we still need to look after people. My husband's a psychiatrist, and he talks about he does home health visits in the rural communities, and some of the patients that he sees don't know how to use high-tech phones, and so televisits and whatnot aren't even a possibility. So we have to be aware of our populations as well. So again, what we're conserving: space, staff, supplies, and staff is very important. I mean, right now is the time, if you have the opportunity. I know at our institution, they're encouraging people to rest up. If you're not needed to be here and you need to do something, now might be a good time to take some time off, because once the crisis hits, we'll need you here full force. And so training people, cross-training if necessary, just conserving and getting ready all the way across the board.
We'll have a slide at the end about, I know everybody's being bombarded by these ideas of self-care, and nurses kind of tend to poo-poo that, you know, I can do it. I think it's becoming really more important now, not just from a physical sense, but from a psychological sense. So we'll get to that on another slide, but just to reiterate that, you know, protecting your own health and well-being and your mental health. I mean, I'm not on the front lines, but I was awake at 3:30 this morning. So, you know, you're thinking about getting enough sleep and eating correctly and all that kind of stuff.
Absolutely. This has been expressed because right now most hospitals, I know that nursing homes, long-term care facilities are restricting visitors. And that's hard. That's very hard because particularly if people life, you know, and you would like to have people there, but you just can't, because again, you're trying to contain the epidemic, the exposure, so it's not worse than it has to be. It's not really abandoning, but it's very difficult. But it is distressing. And I feel like we're abandoning them. But
I think people are coming up with some creative ways, especially, you know, if it's a terminal situation where, you know, a nurse is allowing the patient to use Facebook or something, not FaceTime on their phone and that kind of thing. I mean, it's kind of hard to envision that we have to do that. But I think, you know, again, we're trying to expose as few people as possible. I mean, even though they're talking about, you know, the pregnant women can't have their support person there, but I'm not sure where that's going. But again, it's just kind of not exposing people to what they don't need to be exposed to. I took my husband to the doctor the other day, and I had to go sit in the car because they weren't going to let me in. they greeted me with hand sanitizer and, you know, taking my temperature, but they weren't going to let me in the door. So it's just, it's the way it is.
Yes. So again, talked about this a little bit earlier, but the usual priorities, day-to-day things, you know, respect for patient autonomy, that doesn't go out the door right now. And actually, I challenge all the nurses that are listening to this, if you don't have a medical power of attorney, or if you haven't considered an advance directive, now would be a good time to lead by example, because that's the way, the best way we can honor autonomy. So when people present at the emergency room or whatever, what are your preferences? What are your wishes if this doesn't go well? Have you thought about it? Because when it happens very fast, a lot of these decisions are going to be made by the disease process, and a lot of them maybe have to be made by what equipment's available, what resources are available, and what is going to do the most good for the public at large, the greatest benefit to the greatest number of people. So the allocation of resources is critically important, because not everyone that could benefit from the supplies will be able to have those supplies. And it's a totally different paradigm. And again, the tension of switching that mode, I think, will lead to a lot of moral distress among nurses.
Mm-hmm. Agree.
So this is, we're going to talk about this for a second. One of the questions that I get asked quite often, just in normal situations, if there's not a written DNR and the patient codes, but do I have to start them? And we've talked with legal, the Nurse Practice Act says that you have to initiate interventions that might be required to stabilize it. That's why those written orders and those discussions are so very, very important. But what are we going to do in the pandemic? And that's where we're going to say, if I'm endangered, if I feel like, well, wait, if I go in there, we're out of PPE, and I know that I would be exposed, then I've got other patients to care for that I could potentially expose them, myself, and my family, what am I going to do? And that's where we get to some of the difficulties, kind of how we evaluate the Practice Act and how we evaluate our code of ethics. So I'm going to turn to Kathy.
And there is no algorithm for that situation. There is no, if this happens, do that, or tell me what to do. I mean, it's sort of a gray area, like ethics tends to be. It's not black or white. So, I mean, even in the Code of Ethics and the position statement on risk and responsibility, it's basically the same thing. It's not going to tell you do this or do that. It's dependent upon the situation and your assessment of it. So like Jeannie said, you know, if the patient codes, if you don't have the PPE available, if there's not enough time to put it on, those are all considerations that you have to think about. And also your family, other patients you might care for in the future, because you are a resource unto yourself.
And it's hard. I was thinking about the analogy of if you have an active shooter, someone asked, you know, once, well, do you abandon or do you run off? Well, it's like if you have an active shooter, the likelihood of you being able to stop that bullet, you know, is not very high, nor are you going to be able to protect the patient. So it's a lot of critical thinking and judgment in the moment. So, altruism. I'm sure a lot of you have seen the balcony where people come out and they clap their providers or their songs. The world knows that we're making sacrifices, and they are clapping and cheering us. But again, when does that price become too high, and how can we mitigate that? And I think that's why the duty to plan is so important, is that we can mitigate as much as possible before we even get there. And hopefully, I think all of us are hoping we don't get there, that we've done such a good job planning and preparing and containing. People stay at home like they're supposed to, wash their hands like they're supposed to. This doesn't become as bad as it potentially might be. But the ironic thing is, if we do our jobs well, if we do a good job of containing and things blow over, there will be people that say, see, it was a big deal, they just made too big deal of it. But no, that means we did our jobs well.
Yeah, I mean, altruism is an important nursing virtue. I mean, it's probably why some of us were motivated to go into nursing in the first place. But again, it sometimes comes into conflict with situations that arise in practice. Again, going back to assessing the situation in the moment, I know it's difficult to do, and there's no, do this or do that direction. So it's up to you and thinking in that particular moment if the price is too high.
Yes. So caring continues, and right now that will always continue. Even if a person cannot receive ICU level of care or a ventilator, we will continue to care. Then we'll provide comfort and support in whatever we can. And it doesn't mean that we're picking and choosing who deserves more than the other. It's just you do the best you can for each person, whatever you offer them.
And I think it's fortunate that some facilities like Jeannie's hospital has palliative care services. Again, I'm not sure, like even ethics resources are available for everybody who might encounter some of these issues in their practice. Are you aware of any ethics resources that you have or you can get access to help you with some of these thought processes and thinkings and decisions, those that are not in the moment? But just sort of thinking ahead. I know not every facility, for a smaller community hospital, thinking about, what kind of access you have for somebody to talk to who can offer you some help in thinking through this.
So yes, the transition, fewer choices, fewer resources. You'll have to say no. I mean, when you want to say yes, I'd love to do this for you, but I just can't. And I think the statement is, it will feel wrong, but ethically it is right. And that's, again, just that whole paradigm shift, because we're doing the best we can with limited resources and trying to save as many people and care for as many people as possible. But just expect that it's going to be hard. Expect that you'll have some more stress, and be willing to acknowledge that it's not a weakness. You can't be the tough person. It's going to be okay to cry. It's going to be okay to take whatever time you need for yourself to recover. And my thought is, after this is all said and done, I hope that we as a community of nurses come together and talk about the experience, what we've learned from it, support each other, and just have time to discuss it. I think that's going to be critically important.
Yeah, I mean, I don't think there is much time for debriefing now. I mean, after something happens, it's just sort of like it continues. I think about the people in Elmhurst. It's just sort of like, there's no time for debriefing or thinking through or, what was good, what was bad, or supporting one another. So I think that's a great idea.
So this is an interesting question, and if you've seen a lot of the news blurbs, they're saying, well, we should make everyone that has COVID an automatic DNR, and that's the way to protect staff. And it's like, whoa, wait a second. No, from an ethics perspective, that's a little tenuous at best. We don't have enough evidence at this point that they're less likely to benefit from CPR. Now there's some, and as it's coming out based on the age, based on other comorbid condition, based on and on and on, that a particular patient may not do as well as another, but it needs to be individualized. What is appropriate for that patient? Rather than saying a blanket statement, all patients with COVID should not be resuscitated. You need to make those decisions, or the physician that will be writing the order needs to make that determination based on the likelihood of benefit. And that's just not COVID. That could be a stroke, a heart attack, anything. Those decisions should be based on the factors in front of you. And I think one of the concerns, even again amongst the disability community, is if someone comes in and says, oh, they're intellectually disabled, therefore their quality of life isn't that good and they won't understand, therefore we shouldn't resuscitate them. We have to be very careful in our application of things, and blanket anything, you'd have to have some pretty hard evidence before that could be supportable.
Yeah, I mean, I think that's a very slippery slope, that once you start going down there, and I've seen some, and they use the term mental retarded, that shouldn't be, you know, and the civil rights people are like, you know, up in arms. I mean, it's just ethically untenable that people would even consider that.
I agree. I agree. So I really suggest, this is a great
It is great. Yeah, it is very good.
Scripts. It gives you scripts. It's like, well, what if they ask you this? How might you respond? And it gives you some really nice ideas. I know our palliative care physician, they actually referred us to this site, and I thought, wow, this is nice, because how do you respond to something? Well, why won't you let me come see my dad? Or why are you not giving them this ventilator? Or why aren't they getting the ICU? And these are really tough. And so it's a good site. I do just see it.
Yeah, it's a good prep site, just to kind of read through some of the you know, the questions and potential answers that you might give people. I think it's good to have in the back of your head. I mean, that's what scripting is, just to have sort of responses that you can sort of give people and think about beforehand. Just sort of, again, you know, planning, duty to plan.
Exactly. Okay. Crisis. I mean, we are going to, when the crisis comes, and again, hopefully we can not be there very long, and hopefully it won't be as bad as we think, but there will be difficult decisions to be made. So, and again, we could keep going back to this. It's a different framework, going from patient focus to population focus, the greatest good for the greatest number. And planning, again, is the best way we can keep that as short as possible and cause the least amount of harm.
And that's where those guidelines come in. If anybody's had a chance to look at them for the adult and pediatric setting, that's where the guidelines come in, and the guidelines were built with community input, and they're you know, they integrate ethical principles. So if you have a chance to look at those, I would do that. Again, just as a planning prep kind of thing.
So North Texas has one, and I know many facilities are adopting. New York, several states. I mean, and it's interesting, you can Google and find all kinds of protocols, but like Kathy said, they did a lot of thought, a lot of community input, wanting to think through, you know, what criteria should we use for application, what is just, what is fair, what is transparent. And there's not a perfect system. Let me just put that out. No matter what you do, someone that you would like to give the resource to would not be able to receive it. Again, these are very difficult decisions, and so there's triage review committees that are generally set up as part of these protocols. So if there's tension between, like, well, we have 2 patients that are similar and 1 ventilator, how do we determine who might get it? I've heard everything from picking a name out of a hat, you know, flipping a coin, rock, scissors, you know, there's just not a good way. But that's why the triage committees are going to be very important to help look at that, maybe some contextual features, maybe give some additional insight, and insulate the people at the bedside somewhat, because these are going to be so hard. And to have a voice come in, another set of eyes, and say, you know what, we support you, we understand that, or maybe you hadn't considered this. That's all part of the decision-making parts, right, for setting up. Now, this is a really interesting debate online. It's going back and forth as to whether or not healthcare providers, nurses, and doctors should receive preferential treatment in triage protocols. It's the one argument is, yes, these people are essential. As we said, you know, we have training that can't be replicated instantaneously. They've spent their lives on the front lines, risking it for other people, and they have instrumental value, because if we save, we're going to save other people. Well, that's all well and good, but again, we're talking a pandemic, we're talking crisis. And if you have a healthcare worker, a nurse or doctor on the ventilator, they're going to be very sick. In battlefield triage, the idea is, well, if I can patch them up so they can go right back out and fight the battle, that would make more sense. And so that's the argument against that. And also, should we give any population preferential treatment? A carve out, is that fair? And again, not going to be able to move back right into it. And so it's back and forth, but I know I personally lean towards the no. I think we need to be just across the board, almost blind just, and base it physically or physiological criteria. Who is most likely to benefit from what intervention? Who's likely to survive?
Yeah, I agree. I mean, once you start making exceptions based on somebody's profession, I mean, it's just the same to me as making a decision based on somebody's age or, you know, other criteria that shouldn't really factor into the decision.
Right.
And this is just, I know we're bombarded every day with lots of stuff about, again, self-care and managing stress. And this is from the American Psychiatric Association, and I put the link at the bottom. I think it's really good, and it's very brief. I mean, it might be something that you like post in your unit or wherever you happen to work, just to kind of think about some of these things in terms of yourself, because again, I think nurses oftentimes don't think about themselves in terms of self-care, that, you know, I don't have time for that, or, you know, I got to take care of these people. And but really, I think it's, especially now, I mean, it's in the code, it's, you know, provision 5, self-care. So, but I think now it's really especially important.
I agree. So thank you for everything you do for the folks that are on the front.
Thank you.
And thank you for Denise. She was she's an ethicist at the University of Washington that helped give us some of the ideas for the slide presentation.
Well, thank you, Dr. Robichaux and Jeanie. We really appreciate you taking the time this evening to share this important information with our audience. We do have some time for questions. We want you to use the question box to submit any questions or comments that you may have, and we will begin moderating. So what, if anything, is different to protect nurses from future litigation after the crisis has subsided?
I'm not an expert, and I think probably you would need to have a lawyer, but I believe there's some bills being presented before Congress. I want to say Tammy Duckworth is one that has something to do with OSHA and liability, in terms of you know, not having access to protective equipment. Again, I'm not an expert in legal and that kind of thing, but I think there's some discussion about that in terms of passing some legislation at the federal level.
This is Cindy. The letter that went to the governor from the healthcare industry strike force, that letter requested that the governor adopt crisis guidelines if we reach this point of needing to triage patients for available resources. And in that letter was a request for a waiver of liability for healthcare providers that are caught in this situation. So that is what would protect nurses as well as physicians and other healthcare providers who are faced with having to triage and perform a different level of standard of care.
And I think that's why having a set of standards to guide them so you're not left on your own, and the transparency becomes so important too.
And so there are several questions and comments related to PPE. There's a comment, another way to conserve supplies is to bundle care and to minimize the number of people inside COVID rooms to decrease the amount of PPE rooms. used, excuse me, nurses must be open and flexible in order to keep PPE to protect them in the future. However, some nurses are being fired for wearing their own masks to work, and others are getting fired for telling their patients they don't have enough PPE. What's your advice to nurses in this situation? We know we're in a crisis situation. We know we do need to conserve PPE, and we're doing that because of this crisis situation. What's your advice to nurses and how to kind of mitigate through some of that, knowing that this isn't our normal standard of care?
Well, I wonder, going through the leadership and everything, just talking to them, what are the basis of these guidelines? Are we following CDC recommendations? Can you help me understand the decisions that are being made? I have read stories about the nurses being fired, and I do find that kind of hard to believe, and I don't know if it's happening here in Texas. I would hope not, because it's you're going to need that nurse down the road. But you have to them. If you have shared governance structures, this would be a way to raise the concern at a larger level, and come up with ideas. I mean, perhaps say, well, I know we only have so much equipment, but what if we try this? Not just saying, well, I can't do this, or let's do this, but maybe come up with some solutions and ideas and present it to others, and they'll be more open to those suggestions and allowing you to conserve PPE in different ways.
Yeah, I agree. I mean, I don't think that, nurses are great innovators. I mean, I think we've come up with a lot of solutions for a lot of things, just thinking through them. I know people are like using 3D printers to manufacture masks and whatnot. Again, I think it's incumbent upon the organization in terms of the duty to plan. That's, reciprocal duty they owe their employees. And, firing someone, I just don't think that that's going to continue. It doesn't really make a whole lot of sense. But I guess we'll see if that happens here in Texas. I haven't heard that either.
So there's also a couple of questions in here regarding safe harbor. And the question from quite a few individuals is, does safe harbor apply to a crisis situation if PPE is unavailable to safely care for assigned patients?
This is Cindy. Currently, the Board of Nursing has clarified that if the organization is providing what CDC recommends, the nurse does not have, should not refuse to care for the patient.
However, if they're not providing what the nurse needs, then
if they're not complying with CDC, then the nurse would have grounds to, yes.
There was a recent, I looked at CDC just recently because I was kind of surprised about this bandana business. And it is in the CDC. So there's a lot of contention about, whether this works or doesn't work, and or do we really have to resort to wearing bandanas. So I'm not sure where that's going to go. But, I think if it has to come down to people having to wear bandanas, then, the planning must have didn't go very well.
Well, the code of, and also, Catherine, you're more well-versed on this than I, but the code of ethics does speak to the nurse's ethical responsibility, not only for the care and well-being of their patient, whether it's a community or an individual, but also to themselves.
Exactly.
So if it gets down to the point of wearing a bandana, then I think that the nurse would need to make that decision about whether or not they're able to provide care in that circumstance. At this point, the CDC is making recommendations that are based on droplet transmission, which is what the research is demonstrating. So I think a nurse would be hard pressed to make that same ethical argument if the organization is providing what is recommended by CDC.
Oh, I agree. I mean, if they're providing what's needed, but if they're not providing what's needed, so then you have to assess your risk. So again, as you well know, Provision 8, talks about, situations like that in disasters, and also the risk and responsibility position statement, which I think is on the website somewhere. It's currently being revised, but it says that in black and white, that you're not, if you assess the risk to be too high, then you have to think about that particular situation, the risk to yourself.
Yeah, in fact, this is funny because I was reading through this today about, again, the risk and responsibility in these situations, and it talks about when the moral obligation to provide care is, and there's 4 criteria. It says, 1, the patient's at significant risk of harm. If you don't help, the nurse's intervention or care is directly relevant to preventing harm. The care will probably prevent harm, loss, or damage, and the benefit the patient will gain outweighs the harm the nurse might incur and does not prevent more than an acceptable risk to the nurse. So if you have those 4 things present, again, your equipment is being provided, may not be what the ideal is, but CD says, yes, you can use this surgical mask, it's dropping. Then you do have a moral obligation to try. But if those things are not present, then the moral obligation is less clear, and again, there's not an algorithm. You're going to have to make decisions based on the circumstances you find yourself in.
If you had one thing you would tell nurses to make them feel safe and comfortable with the decisions having to be made for supply purposes versus transmission likelihood, what would you say?
Repeat that again,
Sure. If you had one thing you would tell nurses to make them feel safe and comfortable with the decisions having to be made for supply purposes versus transmission likelihood, what would you say?
Stay aware. I'm just.
I would think that now, again, we have some wiggle room here in Texas. I would talk to my supervisor or nurse manager or CNO or CEO or whoever, and find out exactly what they're planning in terms of availability of these resources. Are they considering potential numbers of admissions and the potential need for these resources? Do they have contingency plans? If they don't have, the N95 mask, do they have other ones available? What is available? I mean, if I have to go to work every day and feel safe, I think I need to know, are these plans being made? They should have been made several weeks ago. But what is being done in terms of assessment for resources, in terms of ventilators and PPE and that kind of thing? I mean, that would make me feel safe and comfortable going to work.
And since we have some time before the predicted surge, are there any predictive scoring tools that you would recommend? I heard in New York, some were using the Apache scoring to determine criticality and survivability.
Again, it depends on the situation, the difficulty. In fact, I had a discussion today with one of the physicians about scoring systems. Depending on how complicated the scoring system is, you may not be able to use it in practical terms. There's one of them is the SOFA scores and the modified SOFA scores. The difference between those two is the SOFA requires more lab work and more things that you may not get those ABGs as quickly turned around as you want. You need data, you need it fast, so you can triage and move on, which is the nature of it. And there's, depending on, again, the person's background, certain chronic health conditions, the scores may be skewed a certain way or the other. That's a lot of discussions going on. What is best practice in assessing people? And I think you have to use a multiple approach, but assessing the person, what you see right there clinically, and then using the best objective scores that you have, but being consistent however you apply them across to all those populations.
We know there's a lot of information coming out daily, and it can be overwhelming for staff. What recommendations do you have for frontline staff and even the C-levels leaders, the C-suite leaders that may be on this call, to ensure that communication is effective and it's daily, and it's in a method that is easily translated to the frontline and up?
I think you have to care for yourself, and I mean care for each other. And it's the little things sometimes that make such a huge difference. Is like, are you okay? Are you safe? Chocolate, you know, just walking around and being aware of your coworkers, and even the leaders. I think there's a tendency to, well, they should know better or blame them, but they're also under tremendous stress right now, trying to make decisions that will affect hundreds, if not thousands of people. So they carry a tremendous load, and, you know, recognizing that we're all in this together. I guess that there's not anyone that's not affected by this pandemic right now.
I think in terms of, you know, validity of resources, I mean, you know, here we have TNA, we have ANA. You know, I think nurses are taking advantage of that. I'm on another chat room with ACN, the critical care folks, you know, and they're putting up some resources as well. So your professional organizations in terms of the validity of the information, because, you know, I hear all kinds of stuff from non-medical people about stuff. You know, and you're constantly bombarded with the TV and people's opinions. But I think resorting to those kinds of, the CDC and those kinds of resources that have some validity, and making your staff aware of that, that these are the valid resources that you should be accessing, and not just, you know, hearsay or the TV and that kind of thing.
And we've heard that staffing may be an issue. I've read where ratios have increased in New York City and New Jersey. You know, what advice and what do you know about crisis centers of care and how that would apply in a staffing situation?
Well, I would fully expect the staffing ratios to change in a crisis situation. Again, there's no other way around it. And I think you will go to the model of doing what needs to be done to stabilize the situation, and that's going to be your priority. A lot of the normal things that we would do if situations were business as usual, you'll just have to let go. And so learning to prioritize what is the most important thing to stabilize the patient, moving on. And I mean, it sounds simplistic enough, but you know, I go to the old ABCs, you know, airway, breathing, circulation, and it changed. You know, what do I have to address? What do I have to address now? And move on, and recognize that you're going to let some things go. There's no other way around it.
And what recommendations do you have to retain frontline nurses who are wanting to resign as frontline hospital staff nurses due to the risk of COVID-19 affecting them or taking it home to their loved ones?
I mean, it's such a personal decision. Nurses have always risen to the challenge. I was thinking of this being the year of the nurse and Florence Nightingale and being on the battlefront and the things that she did. And I thought, wow, in a way, we're walking in history. We are walking in her footsteps. And it's frightening, but it's a privilege. And I think the worst case scenarios, sometimes our imagination gets the best of us. And I'm not saying we shouldn't be cautious and we shouldn't take the warnings and the recommendations seriously, but life is not about risk. And if you mitigate the best you can, I mean, it would be hard to walk away from a career that you love. I understand in some cases maybe the risk to your family is too high, but also be proportional to that risk. How extreme is the risk to you? And do we know? I mean, right now there's so much hype in the media. Just the fact that you walk in, if you're relatively healthy otherwise. And even if you're exposed, will you die from COVID? Will you, if you go home and shower and take care of your clothes and wipe everything down, will you always transmit it? So.
Yeah, I mean, I consider the retention issue, and one of the things I was thinking about today, that in the long run, when this is over, if we get to that point, you know, the impact on the profession as a whole. I mean, we know after 9/11, there was an upsurge in people joining the military because they felt very gung-ho about, you know, going out and, you know, getting the enemy. And I'm thinking about, you know, how will this impact our profession in terms of overall retention, or just in terms of recruitment and people saying, well, you know, I really wanted to go nursing, but wow, you know, you know, I don't know if I want to go through this. And on the other hand, people might say, well, gee, look at all the adulation the nurses are receiving on the news. It's like every day. So it's really a reputable profession. But yeah, I mean, I'm wondering about the overall retention and then the future in terms of recruitment and retention after this has faded. But in the moment, again, I agree with Jeanie. It's really up to the individual and the situation. That if, you know, if that's their priority, you know, safety and safety of their family, then, you know, from an ethical perspective, I really couldn't argue with that.
So it looks like we have time for a couple of more questions. Next question is, a colleague reports to administration that an associate may be exposed to COVID-19. The associate refuses to be tested. What would your approach be in this situation?
Well, that's difficult because people, if they have capacity, they have the right to refuse things. And are they a true public health hazard? And I would also want to know a little bit more information. Do we know for sure that they were exposed? Did we witness that exposure? I mean, just kind of, we have to be really careful about hearsay and rumor and situation about making things worse. But again, from a professional standpoint, it speaks to professionalism. If you were exposed, you do have a duty to self-test, monitor, quarantine, or whatever the case might be.
Yeah, I mean, I think if it was really suspected or observed or proven, not without a lab test, whatever, that, you know, it'd be incumbent upon the administration or wherever the supervisor is to tell the individual they'd have to at least quarantine.
And until we have widespread testing and enough supplies, you know, again, was it everybody that may or may not have been exposed? Right now, that's not a luxury that we have.
And so our last question of the evening is regarding competency. We know that our hospitals are working hard to look at resources and look at areas where maybe nurses, you know, like surgery, for example, where, you know, elective surgeries have stopped, and now we're going to take those nurses and redeploy them to areas. You know, what are your recommendations around competency maintenance if staff are redeployed, and should there be any concerns around that?
I would say start now. Figure out what kind of training they can do. I mean, again, just like I used the titration of drips example, you know, that may not be appropriate for an OR nurse, but there's a lot of things that can be done. But you do need to make sure that you're starting the training before you're in the crisis situation, and then checking those competencies that you're expecting before, again, we get in the crisis situation. Being realistic and giving them the support they need. Otherwise, you're setting them up to fail, and you're setting up patients for potential harm.
I think if you're also talking about maintaining competencies, if you're, you know, the OR closes and you're sent to wherever, so if your competencies get sort of outdated. I mean, we have so much stuff available online in terms of, you know, things like webinars or courses or various things to keep your skills upgraded. And I would think once those things pick up again in terms of surgery, they might have some sort of a, you know, refresher kind of review for people who might have been out for a while doing something else because they're, you know, the ORs are closed. And again, that's in the code, maintenance of professional competence. And ethical competence.
Yes. Well, I know we are right at time, and I want to thank all of you for attending tonight. And again, thank you to Dr. Robichaux and to Jeanie for your time. This has been a great presentation. I think it's very timely considering we are anticipating this surge of patients to come our way in the next several weeks. And if there are questions, if anyone posted a question on the chat that we didn't answer, we will work hard to get those answers and have them posted for you. We will also refer you to our Texas Nurses Association website. We are putting information and resources out daily, and our members also have access to additional resources inside the website as well.
Can I just say one thing before we go? Just to announce that Jeanie is the recipient of the ANA Leadership and Ethics Award for 2020. And Cindy is the recipient of the Advocacy Award for 2020. So we have great resources here in Texas.
That we do, indeed.
And I want to just say to everybody, please be safe, take care of yourselves, and we'll get through this together. I really, truly believe that with my heart. This will pass, and we will come out on the other side better and stronger. And we could tell our grandkids, I lived through whatever. Oh, but be safe. Please be safe.
Thank you.
Thank you.
Bye-bye.
Good night, everyone. Bye-bye.